Next, we go on to the award-winning paper presentation by Dr. Nabeel Faisal, Vishnu Nambishan Memorial Award for the best paper by postgraduate. This was won by Dr. Nabeel Faisal for his free paper presentation.
Good evening. I am Dr. Nabeel from Government Medical College, Kozhikode. I thank organizers of Pedicon and my teachers for giving me this opportunity. My topic is primary immune deficiency, a neglected cause of infant mortality. Primary immune deficiency often causes life-threatening infections leading to intensive care admission and has high mortality, especially in infants. And we need to have high index of suspicion in order to suspect and diagnose primary immune deficiency. And of course, early detection and treatment can save lives. Our objective was to study the spectrum and the outcome of primary immune deficiency in infants admitted in PICU, in our PICU. And we studied from January 2017 to September 2018. It was a cross-sectional study. We used European Society of Immune Deficiency registry criteria for diagnosis. And what made me suspect primary immune deficiency diseases were the Jeffrey Model Foundation warning signs. 10 warning signs were established by Jeffrey Model Foundation Medical Advisory Board containing 10 warning signs. And 2 or more, if present, we considered possibility of primary immune deficiency, and we investigated further. So what we got was, out of total 2,500 children admitted in our PICU, we had 32 cases, that is 1.2% had primary immune deficiency. And among the infants, 2.4%, that is 24 patients had primary immune deficiency. And out of total 186 infant deaths, 13 were attributable to an underlying primary immune deficiency. And most commonly, we had in infancy, we had severe combined immune deficiency, chronic granulomatous disease, and followed by viscoelastic syndrome and autoimmune lymphoproliferative syndrome. So you can see that gender distribution, it is very much high among the males, which is presenting in infancy, and the mortality rate also was very high, 54%. And most common cause of death in our patients were pneumonia, followed by septic shock, and the proportion of infant death attributable to an underlying primary immune deficiency was 6.9%. And in our patient, the mean age of first symptom was 2 months, and it took around 4 months for, on an average, to diagnose that the child is having some primary immune deficiency. So that is a long time. And we also looked into the consanguinity and sibling death of infants. 17% of infants had consanguinity, and 37% had history of sibling death. There were several unusual infections of very severe infections also, like Stenotrophomonas, maltophilia, Codomera omeri. Then there were several organisms like that in our patients. And can also see that X-ray of one of our patients with severe combined immune deficiency. And among the infants in our PICU, the most common were the immunodeficiencies affecting the cellular and humoral immunity, among which SCID, that is severe combined immune deficiency, we had 4 cases, among which one was a JAK3 mutation. And we had 2 cases of immunodeficiency 9, that is due to ORAI1 mutation, and 1 case of immunodeficiency 26 with PRKDC mutation, and 1 patient with Omen syndrome. All these 8 children had severe failure to thrive, recurrent severe infections, and persistent oral thrush. So in the left, you can see a hand of a patient with severe combined immune deficiency. This is a graft-versus-host disease due to maternal T-cell engraftment. And on the right, there is a classical eczematous rash seen in Omen syndrome. And the second common group in infancy, what we found was congenital defects of phagocytic number or function or both. So chronic granulomatous disease, we had 4 cases, all were boys, and confirmed to be 3 had confirmed CYBB mutation, which is the most severe form of chronic granulomatous disease. And we had 1 patient with cyclic neutropenia with mutation leading to deficiency of neutrophil elastase. And it is also, that patient also presented with recurrent abscesses, especially the perineal abscesses were the common presenting complaint. And we had several cases of immune dysregulation. These patients had devastating course in our hospital, familial HLH, autoimmune lymphoproliferative syndrome, Shidiak-Higashi syndrome, all these patients were there. And combined immunodeficiency with syndromic features, we had a few cases, Wiskott-Aldrich syndrome, Digeorge syndrome, Charge syndrome with immune deficiency, and hyper IgE syndrome. All these patients are doing well with antibiotic prophylaxis and all. Now, we had a patient with hypogammaglobulinemia who died at 8 months of age, and another patient who presented at 3 months of age with meningococcal meningitis, and we looked for complement deficiency. It was shown to have a complement deficiency, and we are awaiting the genetic report for the same. And to conclude, diagnostic delay is common in primary immune deficiency. There is a high rate of mortality among infants with PID, and early diagnosis, hence early diagnosis of primary immune deficiency is imperative in order to prevent mortality and morbidity. Thank you.